think so.
Okay, good. So welcome everyone to this webinar of our series hosted by the Fujita Health University Bantanea Alumni Association since 4 years ago already. First of all, I want to welcome Professor Yoko Kato, our mentor. And of course, I want to thank our commentator, Professor Ashish Kumar, and discussants today, who will be Dr. Yasin Felici, Dr. Sukirti Chauhan, and Dr. Shanawat Biswas. Special thanks to our hosts, Dr. Hari Kiran and Dr. Hui Pham. And of course, I'm, as always, very happy to share the moderator rule with my dear friend, Professor Ishu Bishnoi. Today we have, as usual, 2 speakers with very interesting topics. But before starting our session, I would like to ask Professor Yoko Kato to give us a few words.
So, welcome everyone. So I'm very happy to see the dragon after a whole while. So you look very nice. Maybe I think good work every day, I think. Thank you very much for joining. And Sasaki Sensei, I meet him every day. So he works so hard. Yes, at his age, he's very intelligent. Yes, so we are very much expecting his work in future. So anyway, we are very looking forward to your 2 lectures. Thank you very much.
Thank you, Professor Yoko Kato. I don't want to forget to express my gratitude also to Professor Raja and Professor Liu for helping us every time with these webinars. We will start with the first speaker, Professor Kento Sasaki, and I kindly ask my dear friend Ishu Bishnoi to introduce the first speaker.
Thank you, dear Alberto. So I will be introducing Dr. Kento Sasaki, who is a neurosurgeon, assistant professor at Department of Neurosurgery, Fujita Medical University Hospital, Bantane Hospital. And he will be talking on topic on which I published my first original article, that is chronic subdural hematoma risk factors in unruptured aneurysm clipping patients, a retrospective observational study. And I would like to invite Dr. Kento Sasaki to present the presentation. Please.
Can you see me and hear me?
Yes. Yeah.
Okay. Wait. Okay. Thank you very much for giving me this good opportunity for my presentation. Today, I'd like to introduce you the risk factor for chronic subdural hematoma after clipping surgery for unruptured intracranial aneurysm at our hospital. So let me start. While craniotomy clipping for unruptured cerebral aneurysm can prevent subarachnoid hemorrhage due to rupture, it carries the risk of postoperative complications. In addition to infection and neurological damage, postoperative chronic subdural hematoma is a known complication. Chronic subdural hematoma is known as a benign disease with a relatively high recurrence rate, but good outcomes when treated approximately. However, with the aging of Japanese society in recent years, CSDH can be a cause of disuse syndrome, and it can no longer be considered a benign disease in general. So we investigated objective risk factors for CSDH after craniotomy clipping of unruptured cerebral aneurysm at our hospital. The design was a single-center retrospective observational study of a total of 74 patients with unruptured cerebral aneurysm treated by craniotomy between October 2022 and April 2023 at our hospital. The patients were divided into two groups, those with CSDH group and those without CSDH as a control group. The following items were compared: age, gender, BMI, history of renal dysfunction, diabetes mellitus, and antithrombotic therapy, volume of intracranial airspace after craniotomy, and intracranial volume. Exclusion criteria were multiple craniotomy during the study period and history of moderate or severe head injury. Patient selection flowchart. 74 patients with unruptured cerebral aneurysm underwent direct clipping, of whom one had a history of moderate head trauma during the follow-up period, and 5 were excluded due to multiple craniotomies. Of the remaining 68 patients, 18 had CSDH, and the remaining 50 were controlled. For each endpoint, underlying disease was defined as follows. The ratio of the volume of the air-containing parts of the brain to the volume of the auto-extracted brain was calculated as a air-brain index, ABI. The sum of the volume of the aerated area and the volume of auto-extracted brain was compared between the two groups as intracranial volume, ICV. Statistical analysis were performed using chi-square exam and t-exam with a p-value of less than 0.05 considered statistically significant. Regarding as image analysis, using a thin slice of the head CT image taken the day after craniotomy, processed by Xyostation 2. About the aerated area, first, select chest in the preset template, the select lung extraction in the chest preset. Then select the air mass in the cranium in the select object or the mask tool. Finally, use the mask volume of the remaining three-dimensional object. About the brain volume, first select brain in automatically extraction. Then check the area in mask view. Finally, use the mask volume of the extracted three-dimensional object. The ratio of A to B was defined as air-brain index, ABI, and the sum of A and B was defined as intracranial volume, ICV. A demonstration of the aerated area analysis is shown below. Open the target image and select the chest preset. Select the aerated area by changing the angle and leave it. The remaining volume is the volume of the aerated area. Next, I will show you how the brain volume analysis is performed. Open the target image in the same way, and the standard automatically extraction of the brain is performed. The analysis takes about 30 seconds. The resulting image is then checked by adjusting the window level, and the volume is calculated with the mask tool. Let me show you a still image of what I just showed you. I will start with the aerated area. We choose the chest preset. We will get an image like this. We will leave these two triangles for it. In the chest preset, select lung extraction in the chest preset, we will get an image like this. Change the angle, use the object selection. Keep only what we need. The 13.81 indicated in the mask volume is the volume of this. I will now show you a still image of the brain volume analysis. Select the standard automatically brain extraction. Change the window level and check the result. Check the mask display to see if there is too much or too little of the extracted area. Here. The volume of this is 1353 as shown in mask volume. Let me show you an example case. The patient is a 64-year-old male with a right middle cerebral artery aneurysm. Open cranial clipping surgery was performed, and brain health CT of the day after surgery is this. And find the volume of this area. Here is the volume of the air containing area extracted in the previous step. Here. And the mask volume was 56.98. The volume of the brain extracted in the previous step is shown here. The mask volume is 1378.62. The contained portion will be 56.98 cc, and the extracted brain will be 1378 cc. Calculate the ratio and the sum of the two. The ratio is 0.04133, and the sum is 1436, i.e. ABI is 0.04133, and ICV is 1436. The patient had bilateral CSDH 46 days after surgery and underwent drainage. Result. The table below shows the result. The yellow background is used for statistically significant differences. The mean age of the control and the CSDH group was 61.4 and 71.7 years, respectively, with a male to female ratio of 1:0.5 and 1:0.1, and a mean BMI of 23.6 and 22.6. 18 of 68 patients had postoperatively CSDH. There are no significant differences between two groups in terms of underlying disease, approach, or lesion location. There are significant differences in age, gender, ABI, ICV between the two groups, with gender being the most prominent. So, since multivariate analysis was not suitable due to the small sample size, we re-evaluated the significant differences separately for men and women. The table compared the two groups for males. There are significant differences between the two groups in age and ABI, but not in ICV. This is the table compared the two groups for female. Only age showed a significant difference between the two groups, while ABI and ICV were not significantly different. The results of the analysis by sex showed different items in which differences were observed. There was a significant difference in age between the two groups for all patients, males and female. There was a significant difference in ABI in males, but not in females. there was no significant difference in ICV between men and women, which was observed in the overall analysis. Here discussion. There have been several reports on the risk of CSDH after craniotomy, and this study was similar to previous reports on gender difference, but no significant differences were found with respect to underlying disease, including antithrombotic medications. Since there was a significant difference in ABI in men, but not in women, it is possible that not only age, but also higher relative air content on the day after surgery may be a risk factor for postoperatively CSDH in men. The ICV difference observed in the overall analysis may have reflected a sex difference in ICV, since there are no difference in ICV between men and women when analyzed separately. This study quantitatively evaluated the ratio of postoperatively air content to brain volume by sex with respect to the risk of developing CSDH after craniotomy clipping. The results of this study might be useful in future craniotomies, and the result of this study may lead to development of intraoperative procedure for each patient in craniotomy clipping procedures to reduce operating time and avoid complications. Limitations of this study include the small number of cases analysis and lack of multivariate analysis, and the fact that it was single-center retrospective observational study, and also the fact that calculation of air content and brain volume relied on Diostation 2 automatic extraction program, and the possibility that the effect of brain atrophy in addition to age was not considered. Conclusion: older age and the larger air-brain volume ratio on postoperative CT in men and older age in women were suggested to be risk factor for post-clipping CSDH. Thank you for your attention.
Thank you for the wonderful talk, Dr. Kento Sasaki. So now the house is open for the discussion, and I would like our discussion, Dr. Sukriti, Dr. Yasin, and Dr. Biswa to comment. Please. I have one raised hand. Okay, Dr. Dragan.
Hi, thank you for the presentation. It's good to see you here after 1.5 years, I think. I have one question regarding, because I know that you put always drainage in the after aneurysma surgery. In Germany, we didn't put the drainage after clipping, and my question is there some impact of the drainage, yes or no, in your study regarding to the occurring subdural hematoma after surgery? Did you examine that, or?
Okay, thank you for your question, Dr. Dragan. In my opinion, yeah, as you know, this hospital, all patients after clipping, we put drainage, but regarding as CSDH complication, it don't have much relationship between them. Yeah, because we put drainage usually under subcutaneous space, so not so high related on subdural space. So I think so. I think it doesn't matter.
Okay. Thank you.
Thank you.
Dr. Yasin.
Hi, Kento Sensei. Hope you
Hi.
are well. Thank you for your relevant study and the presentation. So my question is about the main time of appearance of this complication. It's late or just after surgery. And my second question is how we can avoid this kind of complication, subdural hematoma, after clipping surgery.
Okay. Thank you for your question, Dr. Yasin. Long time no see. Regarding as first question, in this hospital, usually we see the patient after discharging, after 2 weeks, 2 weeks follow-up we do, and then become longer, 1 month and 6 months or something. And mostly patients found 1 month follow-up time means 4 weeks, 30 days or something. We found the CSDH, because the first follow-up, of course, some of patients have subarachnoid subdural space fluid, but firstly we see the subdural space fluid by Kento medication. Yeah. However, it's when it's not efficient, we decide to operate. Yeah, and that's why the mostly patients treated 1 month after discharging. Yeah. And second question, for the preventing the CSDH for female, in my study, the risk was age, so it's difficult to prevent. But for male, we probably can prevent by containing artificial cerebral spinal fluid before closing dura, probably. Yeah, but I'm not sure. We have to study more. Anyway, thank you.
Thank you.
Yeah. Alberto, you are mute.
Yeah, thank you, Dr. Kento Sasaki, for this nice presentation. Very interesting. I also think that one way to reduce the incidence of subdural is to fill up the surgical field before closing the dura. I agree. I have a couple of questions. So you said that there is a difference in gender between male and female. Do you have any hypothesis to explain this, or it is something that maybe depends on the small number of patients of the series, and so maybe getting a larger series would probably make the results more even between males and female? This is my first question. And my second question is, did you analyze, I don't know if you mentioned it, but did you analyze any possible relationship between the site of the aneurysm and the appearance of this problem in terms of how much did you have to extend your subarachnoid dissection? So I guess maybe this can also affect the risk of subdural. Thank you.
Thank you for your question, Dr. Alberto. For the first question, yeah, this is just my hypothesis. For male, the intracranial volume tend to bigger than female. So probably it's related on to easy made subdural space than female, male group. And also, probably the difference between the shape of skull bone difference between male and female probably related on, but it's just hypothesis. And for the second question, in my study, the between the region, the difference, no, there are no difference between the regions. But it means most of clipping in this hospital are terminal approach. And so in terminal approach, there are no difference. And also for the front interhemispheric approach surgery, basically there are just a few patients of chronic subdural after clipping. So I say yes, and I say no partially. Is it okay?
Yeah. So of course, pterional approach can be more risky for chronic subdural compared to other approaches. I think it's quite obvious because of the location, and probably there is also a more direct connection between the subarachnoid space of the cilium fissure and the space between the skull and the bone and the brain. So there is a more direct contact between these two spaces, but that can increase the risk of subdural. Yeah, probably. Yeah. Thank you very much.
One point that like I'm interrupting. The thing is that with pterional approach, we can directly coagulate middle meningeal artery during opening the dura, and that is now recommended very commonly with embolization of middle meningeal artery to prevent a recurrent chronic subdural hematoma. So this point favors that with pterional approach, originally you can reduce the incidence of chronic subdural hematoma if it is the common etiology for causing formation of chronic SDH.
So do you mean, issue that when you do a pterional approach, you always coagulate the middle meningeal artery?
Not in every case, like they are finding, because in India, mostly we found ruptured aneurysm in more than 90% of cases. So this complication is very rare at my place. But like in Japan or those areas where we are finding unruptured cases more common, and we are facing this kind of situation. So during aneurysm clipping, we can always go for middle meningeal artery coagulation to prevent the occurrence of this complication, and this can be one study based on the findings. That was my suggestion.
Interesting.
Yeah, Dr. Please.
Thank you. My commentary was the same as your issue. That will be probably good for the Sasaki, for the new study, to see is it possible to do in Japan, because pterional is, and there is MMA anterior management is important in the chronic subdural hematoma. So it will be cool to see, because I didn't see in the literature some paper about impact of MMA management during the unruptured, and we are nearby the MMA during the pterional craniotomy. So it will be cool to see that in the future research for Sasaki.
Thank you.
Yeah, Dr. Sogo. Kindly unmute yourself.
Nice to meet you. My name is Shogo Yoshikawa. I'm a first year student, resident of Nagoya University. And I have a question. It's about the measurements of atrophy. So as you said, there is a limitation of the relationship between atrophy and CSDH. And as you measured the aerated area and so on. So I suppose that you can also measure the percentage of atrophy. So such as using the function of pieces. Is there any approach like that?
Thank you for your question. Yeah, as you said, yeah, of course, in Japan, also in several countries, have the newest special item for measurement of atrophy. In this country, some of our hospital has that kind of device, new software. Yeah, but mainly it is used for a screening and for the evaluate health people. Yeah. Anyway, we don't have that kind of software, and also it is now so expensive, and also have the problem. It have not good evidence for the clinical real problems. That's why it's not easy to install it to this hospital. But yeah, we can if we have it. I think. Thank you.
Thanks so much.
Dr. Sukriti, do you have any comments?
Dr. Kento Sasaki is one of my, colleagues who taught me a lot. No questions for him, but yes, your talk was really good.
Thank you.
I missed a part of your talk because there was some reception issue. But yes, the part which I attended was definitely really good. Thank you.
Yeah, thank you. Thank you.
Partiality.
So are there any more questions? Professor Yoko, do you have any comments about this?
Just I want to ask Saxon said, do you usually do arachnoidoplasty almost all cases after the civilian dissection?
Thank you for your question, Professor Kato. In this hospital, especially in my study, mostly patients are treated by 3 neurosurgeons, and all of us do arachnoidoplasty by in their own way. In my case, usually oxycellulose and fibrin glue put before closing dura on the ear and arachnoid. And yeah, one of us arachnoidoplasty by only putting oxycellulose or probably gelatin sponge with fibrin glue are used sometimes. Yeah. Anyway, mostly cases are treated arachnoidoplasty.
Okay, thank you very much. Because I think if we no need to place, not necessarily the arachnoid membrane, you don't need to cut. Maybe I think the limitation is very important. And also at the beginning, just accumulation of the chronic cellular fluid, that is a start to the enlargement of the chronic cellular hematoma. So maybe we should be very careful when you dissect a serial patient. It was an excellent talk. Congratulations.
Thank you. Thank you so much.
Dr. Mikhail, kindly unmute yourself.
Thank you. Can you hear me? Hello. Thank you, Kento Sasaki sensei. It was and nice and excellent presentation. So my question is, have you compared those with antithrombic medication for any other reason with those who developed chronic subdural after clipping and those who were on antithrombic medication like aspirin or any other drugs, so that you can check whether it's a risk factor for the development of chronic subdural hematoma? Have you checked that in your research? And my second question is the control. So are those patients clipped and who didn't develop chronic subdural? Yes, your control.
Thank you for your
So
question. Uh-huh.
the control group,
Uh-huh.
those are the patients who were clipped or who had clipping surgery and they haven't developed chronic subdural. That are your controls, yes?
Yeah, control group after clipping surgery, at least 1 year follow-up, we can find chronic subdural.
So one of the risk factors usually after aneurysm surgery or after chronic subdural, one of the risk factors that were reported is if the patients have this the pneumocephalus or air in the intracranial space after the 7th day of the procedure. So on multiple papers they put it as a risk factor after the 7th day. So have you checked that if you have the image or if you have the data, whether it's compatible with your research?
Thank you. Yeah, thank you for your question. Yeah, for first question, yeah, なんて言ってたっけな。
なんか薬使うかどうか。
そうですね。For antiplatelet agents, in this study, whether we use or not, it's no difference between them. And also for preventing chronic subdural, we don't stop anticoagulate, antiplatelet agents for it. And for second question, yeah, of course, I know the air containing after clipping or after craniotomy is a risk of chronic subdural. Yeah, many papers says like that, but I wanted to know the ratio of air and intercranial space, probably important. Yeah, I wanted to check it. And that's why I did this study. Thank you.
Thank you. ありがとうございます。
Are there any more questions? Thank you, Dr. Kento Sasaki, for this wonderful talk and this wonderful discussion. So I'll now ask Dr. Alberto Felitti to continue the webinar and introduce our next speaker.
Thank you, Ishu, and thank you, Dr. Sasaki, for a very nice lecture, and thank you all of the attendings for the nice discussion. It's time to move on to the second speaker. The second speaker today is Dr. Dragan Jankovic, who is also a friend. He is working as chief resident at the Department of Neurosurgery at the University Medical Center of Mainz in Germany. He's also last year PhD student of neuroscience. He completed the fellowship in vascular neurosurgery under the mentorship of Professor Kato, and besides Japan, he attended also some fellowships in the United States, in Germany, and Switzerland. He is author of more than 30 scientific papers in peer-reviewed journals, and his main scientific interests are neuro-oncology and vascular neurosurgery. He is member of the German Neurosurgical Society, the European Neurosurgical Society and international member of AANS and the Congress of Neurological Surgeons. And today he will talk about the predictors of postoperative worsening and recurrence after resection of pituitary adenoma in elderly patients. So, Dr. Dragan Jankovic, please, you can start sharing your screen. Thank you.
Thank you, Alberto. Did you see my screen?
Yes, we do.
Was day morning I have a little bit problem, but I think that's now is everything is okay. So thank you very much for this invitation. I'm always happy to be here with Fujita people. Today
you can put
about
your slides, Dragan, sorry, in full screen mode.
Sorry?
Can you put full screen mode, please?
It is okay, Alberto. We see it in the full screen.
Oh, you see? Okay, so my problem.
I see also full screen. I don't know.
Okay, great. Maybe it's my problem. Go ahead. Okay. Thank you.
Thank you. So today my topic is something what we are finished with this study 1 month ago, I think, and we present the results in June on the German Neurological Congress, Neurosurgical Congress in Göttingen, and I will also today speak about it. So just a second. So as I said, so my affiliation is University of Mainz, where I'm chief resident, and my homeland is Croatia, beautiful Croatia. But last year I moved for a few months in the Japan to do fellowship that helped me a lot for the learning, for the understanding the neurosurgery. So once thanks to Professor Kato for this opportunity. So that here is our team for this paper, my chairman, Professor Ringel, my consultant, Dr. Konrad, and one of our student, Martin Desch. So, and I will start with the introduction. Pituitary adenoma are benign tumors that arise from the cell of the pituitary gland hypophysis. We know that published literature showed that benign tumors pituitary adenoma are slightly more likely to be affected by in the woman gender. This type of tumor is classified according to the size as either macroadenoma, in the case where we have the size more than 1 centimeter, microadenoma less than 1 centimeter. Adenomas are further also categorized depending on whether or not they produced hormones into endocrine or hormone secreting and non-hormone secreting non-cell adenomas. So we can distinguish, for example, between prolactinoma, prolactin hormone secreting, somatotropin growth hormone secreting, corticotrope adrenal cortex stimulating, or gonadotropic gonadal stimulating adenoma. We all know that pituitary adenoma are the common intracranial neoplasm with estimated, I wrote here from 2015 publication, prevalence of adenoma was 16.7 general population, and they are the third most common primary brain tumor. How we treat adenoma surgical, that's also on paper from our department, from the GNS. Surgical approaches to the pituitary gland have undergone numerous refinements over the last 10 years, and the introduction of new technical skills of endoscopy, neuronavigation, intraoperative imaging opens the new avenues, we can say, of these lesions. And here you can see the illustration of our department of the monosteral in binosteral approaches and schematic field of view by zero grade optics. The second graphic from the same publication, where we can see, and which is I think good for the resident, and that I also here on in this webinar. Here is an illustration of the approach levels in the sagittal plane and the axial plane during the binostrial and monostrial approach, and you can see that we have a few levels. We have 1 to 5 level, and the first level is that first line is the 1 centimeter before the sphenoid sinus anterior wall. The second level is at the level of the sphenoid sinus anterior wall. The third level is center of the sphenoid sinus. The fourth level, or the fourth line, is the frontal wall of the sella, and at the end, inside the sella. And why I choose this topic, because that is something that we talk about in Europe a lot, that the life expectancy has increased in the over the past century, causing a shift in the demographic distribution. And here is the publication from the 2000, where they published that the aging population is a little bit different. You can see here Japan results, UK results, Germany results, and also Italy results. And the studies have suggested that this segment of the population is the fastest growing age group in the developing country. And if the current pace of annual growth in life expectancy continues, the majority of people born since 2000 will live past the age of the 100 years. We will see, is that possible? But that is something what were published in the study. So the aim of study that I present was to evaluate the clinical and the surgical factors influencing the risk of the postoperative clinical deterioration and tumor recurrence. And we perform retrospective analysis, demographic and clinical data, as well as surgical outcome of older patient. And we say that older patient was more than 75 years. And we compared the clinical and demographic data with the patient aged 75 or younger. Knopf's extent of resection, complication, and outcome were analyzed and compared, and we performed univariate and multivariate logistic regressions to evaluate the prognostic impact of age on extent resection and surgical outcome. I have to say just that all patients underwent the protocol in our department before the surgery: hormonal, neuro-ophthalmological, neuroradiological, MRI with the SELA evaluation before the surgery. And here is one important also from our department from the last century, one of the most important in the pituitary. Professor Knoss was also in our department. The Knoss classification is, all that is important in the operative planning, in the predicting the residual the tumor post-resection, and the low Knoss grade are associated with a significantly greater chance of surgical remission after resection. And I will just for the residents say a few things about it. That there is a 3 lines we see here are drawn between the supraclinoid internal carotid artery and intracavernous internal carotid artery on coronal MRI images. And we have the medial tegment, we can medial tegment, we have lateral tegment, and we have the intracarotid line. And these lines are used to define the 4 grades of the invasion. We had grade 1, where you can see here on the picture that tumor remains medial to the medial tegment. We have grade 2, that the tumor extends to between the medial tegment and the intercarotid line. Grade 2 is the tumor extends to between the intercarotid line and the lateral tegment. The grade 3, where the tumor extends lateral to the lateral tegment, and in the grade 3 we have a 3A, 3B, where is the 3A the tumor extends above the intracavernous internal carotid artery into superior cavernosus sinus compartment, And the 3B is that tumor extends below the intracavernomatous internal carotid artery into the inferior cavernous sinus compartment. At the end, we have a grade 4, where the tumor extends. So this is complete encasement of cavernous internal carotid artery. And we also use in this study, the second questionnaire that we used is how we examine the frailty, how we can say that someone is fit and someone is terminal ill, severe ill, mildly frail, or moderately frail. So here in Europe, we used mostly for the retrospective study, the clinical frailty score. This is well-validated scale used to quantify the degree of disability from the frailty. And the frailty is strongly linked to adverse outcome, including mortality, admission to nursing home, falls, and delirium. And here in Mainz, we have a very good sarcopenia and frailty research team for the neuro-oncology, and then I use this clinical frailty scale also for the pituitary adenoma. And here are our results. You have see that we have a slightly male predominance of 75% versus 43%. And you can see that our symptoms, the most common symptoms was visual impairment, followed by a headache, followed by vertigo, and asymptomatic adenoma was in 80% of all patients. And we always think about when the patient has asymptomatic, is it needs to remove or not, and that is a big discussion with the patient and their family. Very important to say that oculomotor nerve palsy are in 3% of the patient, and abducens nerve palsy were just in 1% of two patients. We can also see that the younger patients was statistically significant with the hormonal activity of the tumor. You can see also that cavernous sinus infiltration was almost in the patient with more than 75 years, were in the almost 80%, but in total that is more than 80% of infiltration. Extension into sinus, sensory sinus, was just in 23 of the patient. Here you can see also Knosgrad, extent of resection. We achieved total resection in 70% of the patient, followed by 23% of the patient subtotal resection, and the recurrence were in 23 patients. And now you can see how is the dynamic of the frailty between these two groups. So the younger of the patient, he was 1 of the R scale, and we can see that the patient more in the age more than 75 years were have the higher frailty score. But there is no significance for the tumor volumina, for the operation time, and for the Asia, for the anesthesia score. When we talk about multivariate analysis, what is very relevant, we can say that outcome, that the female gender, that the preoperative hormonal insufficiency, extension into the sphenoid sinus and cavernous sinus infiltration, have positive influence on the outcome. And also we found that the surgical subtotal resection impact the recurrence of the pituitary adenoma in this group. When we talk about the outcome, we found that the postoperatively the clinical condition improved. So directly postoperatively is a discharge. that the clinical condition improved in the nearly 80% of cases, remained unchanged in 80%, in 8%, and worst in 14%, and that was at the short-term follow-up. And at the long-term follow-up is the last patient visit in our hospital. We can say that more than 90% of patients with the age 75 and more and high showed improvement. 6% of patients remained unchanged, and just 1% of patients experienced deterioration. At the end, we can conclude that our study indicates that pituitary adenoma in this age group, more than 75 years, is safe and effective with good resection rate. However, the patient undergoing subtotal resection require long-term follow-up due to the risk of tumor recurrence. Also, patient selection is important, and preoperative evaluation are essential for the optimal outcome in the elderly population. And we think that our findings offer the valuable insights into the characteristic surgical outcome, prognostic factors of pituitary adenoma, also with a particular focus on the age-related considerations. Thank you very much for your attention, and I'm ready for your question and comments.
Thank you, Dragan, for your presentation. Very interesting, and I think there are many data to start our discussion. So I kindly ask our discussants if they have some comments or questions.
Thank you, Dragan, for your
yes.
presentation. Yeah.
Go ahead. Go ahead.
Yeah. Thank you for your presentation and the study. I just have one question about non-functional tumor in elderly patient. Did you go always for total removal, even in cavernous sinus in elderly patient?
No, in the case, so it's the reason why we have a higher percentage of the subtotal resection in the case that the tumor was in the cavernous sinus or so KNOPS 4, that was then subtotal resection is not possible.
Okay.
When we talk about risk for the patient and the benefit.
Yes, and in these cases, when you have subtotal resection, so I have two questions. Do you have experience of postoperative hemorrhage? Because as you know, when you have a subtotal resection, one of the worst risks is to have a pituitary apoplexy, right? So
Yes.
I'd like to know the experience in your center about this. And also, my second question is about how to treat the residue. So if you do a subtotal resection, do you recommend like radiosurgery for the remnant, or you just follow up and observe? I'm asking because in the recent years, at least here, more and more people are pushing towards treatment with radiosurgery. So I'm curious to know, what do you do in your center?
So regarding the hemorrhage, yes, we know that's the one complication that unfortunately can come to after the subtotal resection, and we also have the problems, and so is the reason why our patient with pituitary adenoma, especially the patients with subtotal resection, stay always between 5 and 7 days in the hospital. I read some papers from USA where discharge is the second or the third day in our hospital, in our department. In that's no reason to talk about it because every patient with a pituitary adenoma, because of electrolyte disbalance and possible complications, Addison crisis and other things always stayed 5 to 7 days. We also have a few cases with the hemorrhage, but not directly with the pituitary adenoma. That was the patient with the metastasis in the cella, leukemia, and some other things. In this study, we didn't check but that's the good point. What we can add. We didn't check we found that there is no complication in these two groups, as we don't have a high rate of we have a high rate of the CSF leak intraoperative, and that's always is that the complication from the postoperative complication, because we put the gelita, not gelita, we put the fibrin and the glue, and then after the surgery we don't have then the CFC leak. In some case, if we have CFC leak, we put then the local drainage. But regardless of the hemorrhage, that's the complication. What we also have, I don't have now in my results the number how much the patient has the by subtotal resection hemorrhage, but that is some good point that we can add to our study. Very important. And the second questions, recurrence or residuum, we always make the MRI after surgery 3 months. So we have the before the surgery MRI, and then we have the first control after three months. And we always talk with we have a very good team for the endocrinology who help us with hormones. And we always talk with the patient, is it possible? So we have also patients with the recurrence or with the residue that we send to the radio surgery, but that is not the conclusion of our tumor conference. And so that always is a big discussion how to follow up this patient. But we made that in the 3 months, in the 6 months, and then in the 1 year. And if you see that there is a growth of the tumor, then we go to the resection, resection, or the second alternative in the radiosurgery.
Thank you, Dragan. I see Dr. Biswas has a question.
Well, thank you, Sensei. Sensei, very nice presentation, though I joined in between. A few questions I have faced practically, like in hormone secreting, the functional pituitary tumor, what is your protocol to check the hormone post-operatively? This is number one. And if you see that the hormone level is not below the, below the physiological range,
yes.
That means if you suspect there is a residual functional tumor, what's your protocol? And number three, sometimes due to subtotal resection postoperatively, we have found tumor bed hematoma, but clinically patient is stable. In those cases, what's your protocol? And sorry, last one question. Do you expose cavernous sinus, the paracellular ligament in case of functional tumor, especially the prolactinoma and also in growth hormone secreting tumor? Thank you.
So the first question about the protocol after functioning, as I said, we always talk with the endocrinologist, and they always send us to recommendation which we have agree or not regarding the hydrocortisone protocol before intraoperative, postoperative, and they always ask how long the patient, and we always send the patient after the surgery in the 3 weeks. We send the patient always to the endocrinologist. For the second patient, what was the second?
Second question, if the hormone level is not below the normal range, if it is not within the normal physiological range, post-operative
Yes,
day.
then we have to,
So-
yes, we perform one or the first and second day after the surgery, we perform the hormone analysis, blood check, and then is always discussion between the one meeting between the surgeons, and if we need endocrinologist about the hydrocortisone, if we need to give patients more hydrocortisone or something like that.
Like if it is growth hormone, it's not within below the range post-operatively, then what do we do? What do you do for that patient?
For which patient? For the?
For growth hormone secreting tumor, after post resection, post-operatively, the growth hormone is still being raised. So in that case, what do you do?
Yeah, the problem is that if we have the hormone secreting, we always before the surgery we have to see if we need to resect if the proctinoma, we don't operate proctinoma, for example, but we always, as I said, we always have a meeting with the endocrinologist, and then we decide together with him. So that is regarding for the special patient. There is no protocol now what we do for all patients. So we always get the patient to the patient.
Okay. And if there is a post-operative hematoma in the tumor bed, after incomplete resection, there is a large hematoma, but patient is clinically all right. What do you do in that case? Because we have faced 2 or 3 cases like that.
Yeah, the question is how we know that there is a hematoma.
I mean, post-operative
if the patient is stable, we don't perform elective post-operative CT. If the patient has the headache or some symptoms, yes, of course, we will perform the CT scan. But if there is when patient is stable, we don't perform elective the CT scan post-operative.
Oh, we don't do a CT scan post-operative routinely if there is no symptom. Okay.
Yes, just the symptoms, and then the first imaging is 3 months after the surgery.
Okay, fine. And my last question was, we know that in case of growth hormone secreting or any functioning tumor, there's a very chance of involvement of the cavernous sinus and the medial wall of the cavernous sinus, although in MRI you may not find it. So in that case, do you recommend or do you practice opening the paracellal ligament going through the transcavernous?
No, because it's a little bit dangerous. We have a few of some patients with extension in cavernous sinus, and there is always the questions: is it the decisions is intraoperative, and we always try to in the case that is giant adenoma, it's always to talk about is there needs to operate transcranial also, just not just sub transnasal, but we do not operate cavernous sinus transnasal because then we don't have control.
Okay. Thank you.
Thank you. Sukirti?
Hi, can you hear me? I have a little bit shaky reception.
Yeah, we can hear you.
So, Dr. Dragan, excellent talk. Very nice. I just want to ask you that in your study, was there this option of putting the CSF drain before the surgery, during the surgery, or after the surgery? Or was it like the younger surgeons put the CSF drain, like lumbar drain, and the senior surgeons don't do it? Like, what is your overall experience in the other part of the world?
Can you ask one more time the first part of the question, because I heard a second part of questions.
Yeah. So my question is only with reference to the lumbar drain. What is your take on the lumbar drain in your part of the world? Because what happens is when we are the younger surgeons, most of them put the lumbar drain to be on the safer side. And many of the experienced surgeons prefer to put it as and when required basis, maybe on a second post-op or a third post-operative day. But for the younger ones, we advise, just put the drain and take it out on a second and third day. if required. So what is your experience in that center?
So we don't put elective the drainage before the surgery. I didn't see that here in our department. We put just that in the case that there is need for the need that we have, okay, we will have sure the, but always is we put the drainage after the surgery in the case of the transnodal resection, and that puts some of the residents or consultant is he alone is in the surgery. So if
So
we
it is
don't
never
put,
elective. It is never elective.
never elective, because we always talk with the patient, yes, is there is a reason for the and what is the reason why we put electives, something what we don't need, because that is also infection risk with the lumbar drainage. I know it's not high, but there is a risk of the infections. And if we put we put also, we don't put the tamponade in the nails, just in the giant adenoma or just in the patient with the anticoagulants. In my last clinic, in Professor Nimsky, we put in all patients the tamponade, and then we removed the tamponade the first day after surgery. But here in Mainz, they have extremely big experience, and they don't put any, just in the patient, in the case that patient has some bleeding, or that we have, for example, ISS, acetylsalicyl, in the therapy. Thank you very much.
Thank you.
Yeah, we also don't use lumbar drainage routinely in our center. And I think the major centers performing this kind of surgery now don't recommend to use routine lumbar drainage for pituitary adenomas treated with endoscopy, endonasal endoscopy. Hui?
I have a question. Thank you very much, Dragan, for the presentation. There might be some detail that I missed. I want to ask again. And how do you define the clinical worsening for the patient in the study? For example, you define them by the worsening of the presenting symptom or any other symptom, a new onset or new symptoms after surgery, or any like general outcome scale?
So presenting of the new neurological symptoms, or worsening or preoperative symptoms.
So, for example, if the patient presents with the visual impairment, but then the visual improve after surgery, but then the patient develop some kind of endocrinologic problems. So, is that a worsening or is that an improvement?
So there is, if we have a new deficits, neurological deficits, it's always the question is which endocrinological worsening will patient have? Edison crisis in the complication for example. But if the patient, as I said, we put always the patient preoperative in the for the ophthalmologist, and we put the patient always postoperative for the ophthalmologist. And in the case that we have, for example, the patient who have improvement of the but have the complication from another side, then is that for patient that had worsening in our group.
Do you have any idea or a study that you evaluate the predictors for the improvement of its presenting symptoms like visual impairment or endocrinologic problems?
For endocrinologic is, I don't know. I wrote for the paper because we write now the paper. I have checked about the ophthalmological, and in ophthalmology there is some good paper in the literature that I can send you per email about the improvement of the some clinical ophthalmological symptoms that patient had preoperative.
Yeah.
But for the endocrinology, I don't know. Probably Alberto, did you know something? I never read something about it.
Yeah.
Study about it, yeah.
No, I don't have anything in mind right now, actually.
Yeah. For endocrinologic problems, have you any got idea about the imaging on MRI for the pituitary gland, the normal gland, before surgery and during surgery, in your experience?
Yeah, the problem is what we have problem for the first MRI, because it's always the problem when you perform after the surgery directly MRI. It's always a question: is that some material, or is that the tumor rest, or is that okay bleeding? We know, but how it looks like pituitary before and after. Now I cannot say that on the MRI. Yeah.
Yeah.
Because I present here the study. In the study we didn't put some comparison between the imaging before and after. Yeah.
Mm.
We have the size, we have the vertical diameter, we have the horizontal diameter, we have the 3D scan. Yes, but we did not examine the pituitary gland before and after. That we didn't examine in the study.
Yeah.
Yeah, probably it's easier to detect the pituitary stalk than the gland itself, right?
Yeah.
Both before and after surgery, but not easy. I agree with Dragan, not easy, especially after surgery, to detect on MRI these structures. But of course, during surgery, you can see them very often, right? So the surgeon who does the operation is aware if the pituitary stalk and the gland are still there, or they have been sacrificed. Usually, not always, but usually.
Yeah. Yeah, thank you.
No, I think usually we can see the pituitary gland, maybe it's compressed, maybe the posterior side or in anterior side.
Yes.
Yeah,
If
yes,
you can, yes,
yeah.
and if you do the enhanced MRI, it's much better information.
Yeah, well, we always try to identify the location of the pituitary gland before surgery by MRI images, and try to preserve that during surgery. Yeah.
Thanks.
Yeah, thank you.
Thank you. And I see Dr. Michael raised his hand.
Okay, thank you, Dragan. It was an excellent presentation. So I had some internet connection problem, so I might have missed some of your presentation. But my question: so have you compared fluorine electrolyte and DI complication in the elderly and young, like below 65 or below 70, and the elderly patient? Is there a difference post-operatively DI incidence?
Okay, I think that I understand good. So we didn't find there is no statistically. So we find that there is a percentage is different between these two groups regarding for example the postoperative complications. For example, the CFZ leak, for example, while we found more CFZ leak in the younger patient than the older patient, for example. But we didn't find statistically in univariate and the multivariate analysis some statistical difference between these two groups. There is just difference in the percentage between the groups.
Thank you.
And the reason is also that we have the 75 years. I think that's comorbidity. We can talk about the 60 or the 65 years. So we put the range of the age probably higher that we need to put, yeah, because the 75 of yours is the patient. I will expect this patient have a more comorbidity, but we did not find in these two groups.
Okay. The reason that I ask you is in some literatures, after transfemoral surgery for the elderly, the fluid and electrolyte MDI, they say it's more common in the elderly than the younger. So if you have anything similar, that's why I ask it. Thank you.
Thank you very much.
Thank you. Is there any other question from the floor? So if there are no other questions, I would like to thank Dr. Dragan Jankovic for a great presentation and discussion. And maybe we can move forward with the self-introduction of the new fellows at the Fujita Bantane Hospital. I know that there are two doctors from Ukraine. Are they connected? Dr. Daniel Kostyuk and Dr. Kirilo Dukovsky?
Yes, they are.
Yeah, please, can you introduce yourself a little bit, something about your country and your research activities?
Hello, it's Daniel Kostyuk, but I should remind that I'm not doctor, I am a resident, second year. So
Can you
now
introduce
I'm
yourself?
Daniel, we can't see your face.
Yeah, unmute, please. We cannot hear you and not see you.
So it's a little bit hard for me to talk. Maybe I can talk with you more correctly and more concrete after 20 minutes.
I think after
it's too late, I think.
Yeah, 20 minutes we will be finished. Is there also Kirilo with you?
So, okay, I will try to tell you something as I can.
Yes.
In this case. So, I'm from Kiev, from the Institute of Neurosurgery, Ramadanov. Interested mostly in the vascular surgery as open as also endovascular. It's my first foreign fellowship. And first, because it's now it's due to the war, it's very hard to go out of the border in our country. All men should stay in Ukraine from 18 till 60 years. What I can tell you also about we are a country which try to even in very terrible, even catastrophic situation, go ahead, trying also to upgrade our opportunities of neurosurgical treatment. Besides, we have the third station of calculating for coordinates in DBS for stereotactic surgery in Uzhgorod. So now we have 3 centers in Ukraine which make stereotactic neurosurgery. Also, our government trying to buy and get more angiographs, which helps firstly by program of immediately help in the ischemic stroke cases. So when people with ischemic stroke, where they are going into the hospital, not in the center of district, but in the nearby stroke center, get the thromboectomy and thrombolysis. And we have first results of this program that it's decreased the number of invalidization and increased the number of good recurrence, because time is the brain in this situation. So maybe you have a question and I will tell you more if you want.
Yeah, thank you. Thank you very much for your self-introduction and for explaining the situation in your country. Of course, we are all very close to Ukrainian people in this difficult situation. And yeah, about young Ukrainian neurosurgeons, we wish to offer you more and more chances to get some higher education. Professor Kato is doing a lot. But we can involve you also in our next webinars and initiatives. I kindly ask Dr. Kirillo, I think he is connected now, to introduce himself.
Do you hear me?
Yes, here you are.
Okay. Hello, everyone. I'm from Ukraine. My name is Kirilo Dukhovsky. I'm a neurosurgeon. I work about 7 years till I end my fellows in Ukraine. I work in a pediatric neurosurgical department, also doing operation for adults. We're doing all kind of operations. It's starting from the trauma, tumors, stereotactic operations, vascular pathology, all kind of either kids and adults. Our department situated in Kharkiv. It's about 2.5 million populations for this city, but demands for the war. Now it's about 1 million citizens.
Thank you very much.
Questions.
Thank you very much for your talk, and we wish you all the best, also for your experience at Bantane Hospital, of course. I'm sure you will get a lot from this experience. So if I'm asking the audience if there are questions for the new fellows, or maybe Professor Kato, you want to spend some words about this and also about the speakers today.
Yeah. So Daniel's father, I know him. We work together. And also Daniel, maybe father, the brother is also the neurosurgeon, all the doctor's family. And Kirill is just 40 kilometers from the border of Russia. So they have so many wounds, the patients. So we saw the picture, it's nice. So I think it's some very, just 1 month limitation for out of the country. And he said he crossed the Ukraine country by car, almost 15, 16 hours. Then they can wait at the border of the Poland. So I think very tough journey from Ukraine to Japan. I think we very admire them. And since they came here, that they joined not only the open surgery, but also the all endovascular surgery. Now we have 4 board certified good endovascular neurosurgeon now. So they showed them, of course, not only the flow diverter, but also web. We have so many web cases now. So I think hope they can, as much as the knowledge and skills with them, and they can share their colleagues once they return their home. Now, I see. Thanks very much.
Thank you.
Thank you, Professor Kato. And before closing, I think Dr. Liu can show the flyer for the next winter seminar. Dr. Liu, are you? Yes.
Thanks, Beto. I would like to introduce you to the 8th Fujita Bantane Winter Seminar. this is the 10th anniversary of the winter seminar, which will be held from February 8 to 13 next year. And this time, this program will be organized by Fujita Alumni itself, headed by Professor Alberto Fedenti. And as usual, this workshop we will have a combination of live surgery, hands-on workshop, symposium, and this time we have an additional excursion where you will bring to brought to be visiting some interesting place in Nagoya. And this seminar will be held in Bantane Hospital itself. I'm showing you the next page. And the one with the tick are those who already confirmed joining. We have more than 27 professors who have agreed to join us in this seminar. More to come, more to waiting for their response. So these are those professors who have agreed to join us for the 4 days programs. And we also would like also to extend our invitation to other organizations under SNS, including YNS Committee, WIN Committee, and SNS board members, and also continental representative, as you can see in the lower part of this diagram. Fully, our continental representative can also join us. So we would have, at the moment, tentatively, we will have a vascular anastomosis workshop, carotid endarterectomy workshop, neuroendoscopic workshop, and interestingly, we have the Professor Kuwayama and his team agreed again to join us with his endovascular workshop. And we also have a live surgery. We are planning not only a live surgery at Bantane Hospital, and we may have live surgery telecasting from other hospitals during this seminar. As I mentioned that there will be a excursion, and also at the moment we limit to 20 young neurosurgeon and neurosurgical residents. So you may copy the email below, winterseminar@gmail.com. You can share it with your friends, colleagues, young neurosurgeons, residents. You need to produce 2 documents. One is letter from support from your head of department, and one short description why you should be selected in less than 500 words. Tentatively by 30th of November. The date may be changed later depending on the organizing committee. And this is the rough program. So first day on 8, we will have a morning till afternoon workshops, including IBR hands-on workshop. The second day we will have full day symposium. The third day and fourth day we have a pre-op discussion and live surgery both days. And in the evening, as usual, we have a keynote lectures. On 12th, the 5th day, we will have a YNS presentation and an award session. And in the evening, we again have a keynote lecture. And the last day in the morning, we will have some trip outside the hospital area. And we will end with a fellowship dinner. And these are some of the lectures, but it's subjected for changes. They have agreed to join us. This is on the full day symposium. And we will show more update on the program, especially for the keynote lecture. That's all I would like to share. Thank you.
Thank you, Dr. Liu, for sharing this wonderful program. I think this is a very important initiative because we all remember with great pleasure the past winter seminars. Unfortunately, it was necessary to interrupt them during the COVID era. The last one was early in 2020. And they are of great benefit especially for young neurosurgeons. And the fact that we are recovering this appointment is really something great, I think, for young neurosurgeons. Dragan, do you want to say something?
Yes, I had just a question. That is in person.
Yes.
In person, yes.
Okay.
then I will come, I said.
Because
Yeah,
Dragan, you wanted to come Japan once again because of your research
Yes,
work, I think. Yeah.
yes,
It's a
yes.
good chance for you.
So
I
it's
think.
planned. So it's planned.
Yeah, it's 10th anniversary
Yeah, very
meeting.
good.
So
Very
yes,
good.
you should come, please.
I have
yeah.
the book.
Maybe Shogo
So
will
save
join
the
us
date.
again.
Yeah, save the
He's
date.
the seminar is tempting. We feel like going back and becoming a student again for 5 to 6 days.
Yeah, I think it's very important for education, but also for gathering after maybe with some people so long time. So great chance from many points of view. So thank you, Dr. Liu, for showing the flyer to us. And I would like to conclude this webinar. Again, thank you to all our discussants, to Professor Ishu Bishnoi for co-moderating with me, Raja, Liu for their constant support. Thanks to the speakers, thanks to the new Ukrainian fellows who are very welcome to join the Alumni Association, of course, and our activities from now on. And thank you, Professor Yoko Kato. I would like to kindly ask you a few words to conclude this webinar.
Just I want to mention about the Shogo Yoshikawa. He's joining today's webinar. Where are you now, Shogo?
I'm in my home, and yes,
Japan.
so yes.
Okay. So when do you go to Dragon's place? What is your plan after this? Just you can tell us where you were in the world.
You have been to many places, Shogo. It's good to see you again. After you visited Verona, you went to Scotland, right? To Edinburgh.
Thanks so much. May I introduce myself?
Yes, please, of course.
My name is Yoshikawa, and I'm first year resident, a neurosurgical resident of Nagoya University, and I'm on sabbatical period. I took for a half year, and this is because I'd like to go to other country to see a lot of different things, and I also like to learn English first. And thanks to Professor Kato, I've introduced it to Dr. Albert and Dr. Andreas, Edinburgh University, and so last May I've been to the Verona University thanks to Dr. Albert, and I watched a lot of operations, and I communicated a lot of residents and make a lot of friends, and then after that I also been to the Edinburgh University. After that, I also been to the Tanzania, the observatory. And now I come back to Japan again, and I'm preparing now for the next observations, observatory, and for Toronto and maybe Germany. Thank you very much for listening to me.
After Germany, you go to the Canada, yes?
Yes.
So maybe
Many
you should go
experiences for
to
you.
Latin America, maybe.
Maybe, yeah.
Okay. So I think it's a very, very good experience at your age, I think. Then you back to your work, okay?
Yeah. Thank you so much.
We are waiting for you, Shogo.
Dr. Dragons, I'm very sorry about this.
It's okay.
Okay.
It's okay. You just need to come, so we are waiting for you.
Yeah, thanks so much.
I told all doctors in the department and our we have our anesthesiologist that she's from Japan, from Yokohama, and she know that you come. So everybody waiting just for you.
Set up, finish. Okay, thank you very much, Dragan.
Yeah, thanks so much.
Okay, thanks. Thank you. So, Albert, thank you very much.
Yes, thank you, Professor. Do you want to say a few words to conclude the webinar?
Yes, thank you so much. So today we have lots of course, the excellent two talks, and after that we have lots of discussion among so many doctors. We are so happy to see your face. So hopefully, maybe I think next year we can gather maybe as many as possible, please. Thank you very much. See you next time. Bye-bye.
Thank you, Professor Kato. Thank you to all of you, and see you next month for a new webinar of our series. Thank you. Have a good day or night.
Okay.
Bye-bye.
Bye-bye.
おやすみなさい。